This is the session on the custom cataract surgery. Cataract surgery is nowadays a refractive surgery, and everybody doing is a very good cataract surgery with the Phaco, SICS. We have the multiple option of the lenses available. Now, day by day, the patient's demands is increasing, and how we can perform and give more clear vision, more unaided vision in a difficult situation. We'll try to cover some of the aspect of the cataract surgery. With us, I have Dr. Ashok Shroff from Navsari, a senior cataract and retinal surgeon, and my teacher. Then we have Dr. Mahipal Sachdev, our ex-president. He will be coming. Dr. Vijay Nichlani, the scientific committee chairman of the MP state. Dr. Rajesh Joshi from the Nagpur is a leading cataract surgeon from the Nagpur. Dr. Harbans Lal will be joining soon. He is the vice president. So first is the, till Harbans join, Dr. Ashok Shroff is going to highlight on the astigmatic management and cataract surgery. For every speaker, we have the time schedule of 10 minutes, and later on we will have the discussion if time permits. Sir.
Good afternoon, everybody. Thank you, Dr. Rajiv, for allowing me to participate in your beautiful course, because the cataract surgery expectation of patients have increased a lot because of the advancement in the lens quality, premium lenses and for anything. We need to really not only doing Phaco, but then the patient is concerned with the vision, and that is more important for patient. Now, my topic, whatever been assigned to me, is to how to tackle the astigmatic part. 70% of patients have astigmatism, more or less, one diopter or less, and 20 to 30% of patients have cylinder more than one diopter. Astigmatic correction in such cases becomes must, and what are the options? Either you plan your axis incision in such a way that on steep axis particularly, so there's some part of the astigmatism corrected, or you may have to have limber relaxing incisions, or you can have arcuate keratotomy or toric IOLs. Limber relaxing incisions for dummies is there is one nomogram. If it is less than 0.5, up to 0.5, then one incision in a half clock hour you can plan. If it is more than that, 0.75, 2 incisions in 1 clock hour, 1 diopter, 2 incisions in 1.5 clock hours, 1.5 diopter, 2 incisions, and 3 diopter, 2 incisions in 3 o'clock hours. However, a little more for against the rule and for younger patients, and little less for older patients. However, you have to personalize your nomogram. There are various companies, they have their own calculators, and you have to, whichever lens you choose, you have to go for that. My choice, otherwise, normally, because my surgical induced astigmatism is more or less 0.5 the cylinder. So if that up to that cylinder pre-operative, I don't treat. And I would wish, on the contrary, that at the end of the day, the patient should have minus half cylinder at 90 degree. So that will give the patient about 6/9 and 8 vision without glasses, even in monofocal lens. If it is more than or equal to 0.75, then I would go for the LRI. But if it is more than 0.75, then toric IOL. There are different markers available for that. And here, either you have to, this is very good markers now we used to do for the PRKs and all, the RKs and all. And then the reference marker with the bubble is more better, so that you can have keep the bubble in the horizontal position. And then these are the marker, the ring with the different axis. You can mark it, your plane of axis mark, you can mark, and with this you can mark the pre-existing cylinder axis. Axis mark, you can mark on either on the slit lamp with the horizontal slit, and then with this you can see that the horizontal slit is coincide with the marker, the marks. And then there is another method. This is my choice. I do it in the OT only. That patient is made to sit in the and ask the patient to look straight ahead, at a long distance, and then you can, with this bubble marker, you can make these marks. The reference marking, I would be covering a little short about the limbal relaxing incisions. You can see that after marking on the cornea, this is my surgical plane incision, the mark, and then axis. And then this is the marker. One incision you can see here. This must coincide with the cylinder on the cornea. And then there are 8 markers. So one between the two, is 1.5 o'clock. So here I'll be doing, I'm doing 2 incisions, and between the 2 incisions. So covering 3 o'clock on either side. But this has to be done on the intact eyeball. That is very important before you start your phaco. There is a patient, female aged 74. Patient wanted to have panoptic toric. The axis is marked. You can see that. The phaco is done. And then you can see here, there's a toric panoptics with the axis marker, the 3 dots. And then, can you go back? बैक नहीं, वो बीच में से आगे वाली वीडियो चलाना है, थोड़ा आगे जाओ, 1 मिनट।
सर लिंक नहीं कर रहा था आपने साहब, ये
क्या हो गया?
लिंक नहीं है सर।
लिंक है? ये स्लाइड बैक जाओ, बैक यहाँ से करो। Okay. Okay. And when the lens is inserted, it is very important that there are 3 in Alcon lenses. There are 3 dots. That lens, the dots they have to be aligned with your original the marking on the cornea. It is very important. You must make it proper. Here, there is another type of lens, size lens. You can see here, this is my case where I already marked it 110 degree, and then the axis is marked. And after the cataract extraction and everything, the lens has to be placed in the bag, and then you can see this is wide lens. It is a small little not dots, but the line, so that is easy. You can again, you have to be very careful that the lines are coincide with the marking of the cornea. In my case, in our series now, the most important is the toric lenses. The average was -2 cylinder. It ranged from 0.79 to 4.16. And post-operative it was -0.15 cylinder. the range was 0.75 to +1. And multifocal toric, it was average was minus 1.52 cylinder. It ranged from minus 0.85 to minus 2.71. And the average landing was minus 0.5 cylinder. The range was 0 to minus 1.5 cylinder. Thank you very much.
Thank you, Dr. Shah.
Any question?
Anybody? We can have the discussion later on.
Just
Anybody wants to add something, or Vijay kuch?
I would like to add one more.
Yeah, sure.
Two couple of sentences. In spite of all efforts, everything, at the end of the day, it is a possibility you will end up with the astigmatism. And everything, your closest case now. So I have, in my hand, couple of cases, we have gone for laser refractive surgery. And that gives excellent result. Of course, you cannot charge this patient, or you are already charged. But then that is the best option. Thank you.
Is that counseling is very important?
Very important, yes, sir. And particularly for the premium lenses, very, very important. We invite Dr. Rajiv Choudhury for his presentation.
Small.
The astigmatism is very high, more than 1.5. And then we did, but then I'm not very happy with the LRI. Ultimately, after coming the LASIK, the toric lenses now, these all initially all in small 0.5 or 1.75 you can do it. But then higher cylinder, more than 1.5, I think the toric lenses are best. Because after healing, suppose you have planned in very nicely, but after healing, again it recedes, the cylinder comes back.
Timer is not visible. नहीं, यहाँ से visible नहीं है. So, good afternoon. My topic is cataract surgery in a small pupil. Because once we face the complicated situation, how much you have done the counseling, but patient expectation is always high, whether it is a small pupil, hard brown, cataract, subluxated, whatever it may be. In spite of all counseling, they compare with the normal cataract surgery. So how we can improve the quality of vision in this type of cases? We have the small pupil that fails to dilate and can obscure visualization. There are the multiple reasons for this. So first, pre-operative caution, careful examination, and what we do for all the patients, and the routine examination. There are multiple methods. We can have the stretch pupilloplasty, multiple sphincter iris tube, pupil ring expander. So this is the case of iris hook. Careful insertion, a traumatic insertion. We need a 4-point incision, which probably most of us are doing nowadays. It is just to, I can just slightly fast. The advantage of, 4 hook. Only you have to take care that you should not rupture the anterior capsule. You can try it, but initially the first incision, once you are implanting the hook, you should stretch minimal, because that it will give in more stretch on the, and later on according to need you can enlarge. So in this way you have full control over the pupil, and you can remove the very hard brown cataract with ease, taking the full care of the parameters for the hard brown cataract. Pupil not come in between. So this is the advantage of iris hook, that if sometime you come across this type of the cases where the blade is hanging and you are not able to, in this the Mulligan ring and other ring will, it is an old video, will give a central dilatation, where with the help of the hook you can have the eccentric dilatation of the pupil. Like this, you place two, and you can put only two hooks in this, and with this brown cataract with the overhanging bleb covering the almost upper 1/3 of the cornea, you can remove and do the phaco very well. So this is the advantage with the hook, that you can eccentrically can stretch the pupil in desired direction. Sometime in between surgery, if your pupil get constricted, in this condition again the Mulligan ring probably will be slightly difficult to place, so you can use hook and pupil is not dilating. You can, after dilation, you put some viscoelastic, give some semi-dilatation. You are in between of the surgery. You can place the hook and the same surgery you can perform. Only thing you have to take care that you should not catch hold of the capsular axis margin. Just pass the spatula between it, elevate the iris so that you are far off from the anterior capsule, and you can give a full dilatation, and you can. So iris hook is the advantage of this iris hook in this situation. Don't rotate the globe too much, as that increases the chances of iris retracted slipping. So once we are stretching, it should not rotate it too much. There is a multiple complication. You can inadvertently cut the anterior capsule. You can tear the anterior capsule, which can lead to the extension to periphery. So in intraoperative loosening and dislocation of hooks, iris aspiration and chafing is the common with the iris hook. There are other multiple dilator mechanism. I will just skip. We'll come to our routine Mulligan ring, rectangular device, helicon coil made of 5-0 polypropylene. Use the scroll principle to catch the pupillary margin. It is very easy to use. Simple. There is a loop. First, it is with the injector. You just go, engage. Then you have to tilt your injector on the one direction so that you can catch hold of the iris on the one direction. Then just reverse. Once you hold, then you just turn in the opposite direction so that you can catch hold. Sometime, because in the manipulation, your antechamber get shallow, you just inject in between, and the upper loop is inserted with the help of the hook. Now this iris is fully under your control. You can very well. Now another thing is the importance, and while removing, you have to take care that this loop should not get entangled with the margin of this Mulligan ring. So they should be clear off from the these loops of the Mulligan ring, because sometimes that's engaged, and when you remove, the lens may come out with this. So just disengage the upper coil, and then it's a very simple and you can come out with this. And so in this way you can plan your multifocal also in the small pupil if you want, toric, and so these are the help you can get with the. These are other device but which is not readily available. I will just show that this is a hard device you can go in, and this is a polypropylene plastic material. Advantage of this, you can do the phaco in a high aspiration, high flow rate, because there is no iris margin anywhere. So if iris is floppy, it will not come to the probe, and you can work with all your routine high flow rate, high vacuum, whatever you want with the good machine. There are another Bhattacharya from the Calcutta, he has designed. And the same principle, what it works on the Moluccan ring. So, another thing, what you can do in the small with the advantage, you can use femto laser in a small pupil. Advantage that it gives a clear-cut margin, and you can perform your rhexis well. You can slightly stretch, and you can do with the control parameter without using any add-on hook, or because your nucleus is already broken in the pieces, and it is very easy to chop this fragmented nucleus, and you can very well remove the cataract in the mildly dilated pupil. So this is one of the advantage of the femto. So in the short, there is a numerous pupillary expansion method available. Choice depend upon the preoperative status, interoperative status, and surgeon's skill and experience. So appropriate use of the pupillary expansion method give a safe phacoemulsification with the better surgical outcome and good post-operative. We have to take care of the pupillary function post-operatively. Suppose we stretch too much and your sphincter is damaged, then later on that pupillary function is lost. So you have to take care of this. So in short, thank you.
Thank you, Dr. Rajiv. Anybody would like to ask questions? Rajiv, I would like to, what I do normally in such cases now, rather than iris hooks, I use capsule care. Capsule care either before starting the phaco, or before making the rhexis, or even after making the rhexis. What I have found, the design of the capsular rhexis is such that there is always some gap in the periphery between the capsular hook and the cornea and the iris. So while the iris hook is a straight, like a old man's stick, so there is hardly any gap at that between the iris and the cornea. It means limbus. So if you go through the limbus of the cornea for any maneuveration, it always pushes the iris or catches the iris. While in capsule care, what I have found, there is a little gap. So it is always easy and better. And another thing I have found, that suppose people become small intraoperatively. In the capsule care, it doesn't doesn't bring a lot of tension on the margin, the rhexis margin. So hardly it gives a tear. Of course, you cannot pull too much, but then hardly gives tear.
Capsule care basically used to hold up the capsular
but
margin.
Then, that is what I tell you.
The angle that gives
but
the specific
that's why I tell you, it is good even to retract the iris also.
Another problem with that the lower loop is slightly larger. So if you cannot stretch much,
please try, you will enjoy.
And the best is the ring, because it doesn't give the trauma much to the sphincter. So ideal way is to use iris hook. Used to be used earlier, and it is quite cheaper. But one of the advantage of iris hook or capsular is that the function is the same, that you can eccentrically stretch the pupil, which we cannot possible with the Moluccan ring, Bhattacharya ring, or all other rings.
Any intraoperative drops you have found useful?
Initially, we used to try the dilator, but
okay.
But
because it helps in if you are not dilating the pupil, means no preoperative dilating drops, then it helps. But suppose the pupil is refractory, it doesn't work.
Everybody dilates, the preoperative dilate.
No, now the trend has come, they put the drop intracameral.
That to fasten your patient time.
Okay.
Okay.
Thank you. Now invite Dr. Harbans for his presentation, customization in soft, mature and hard cataract.
इसके बाद हाँ लो अच्छा हरबन विजय इसके बाद
नहीं PowerPoint नहीं customization.
Sorry, PowerPoint is in the read.
पेन ड्राइव लगा के देख लो अच्छा
कॉपी नहीं करवा था क्या?
नहीं कॉपी
Our Vice President-elect get ready. I invite Dr. Harbans Vijay ko bole. Dr. Vijay Nishlani to speak on the subluxated cataract management. As we discussed earlier also, that in subluxated cataract, again there is a problem and there is a tilt. Stability of the lens is one of the issue, and that is going to affect your quality of vision. So how you can cover, Dr. Vijay Nishlani will be going to deliver. Okay.
Can you connect it, please? So coming to another complicated situation. Before I start, I must thank Dr. Rajiv Choudhury, sir, our Chief Instructor and Scientific Committee AIOS, for allowing me to share my thoughts regarding this subject. The subluxated lens is again one of the challenging situation. Whenever we get these variety of cataracts, they have got a different degree of zonulolysis from 3 o'clock to 270, and pan-zonulolysis cases have also been seen. So let us see a few of the cases. How do we go ahead with these patients and can complete our job with phacoemulsification or the closed chamber surgery. This is what basically we do nowadays in these cases. So these are the different scenarios that you get a different variety of zonulolysis and with a different degree of a density of a cataract. So you have to mind both the things, the level of zonulolysis or the degree of zonulolysis and the density of the cataract. So just a few definitions. Subluxated, if it is seen in a pupillary area, dislocated lens means it is not seen in a pupillary area. Ectopia lentis is given to a congenital situation. Etiology could be genetic associated with systemic disorders. It could be associated with different ocular pathologies, and finally it could be a traumatic one. So the problems, what are we going to face with subluxation of these lenses? The extreme of refractive error. The refractive error suddenly changes and patients get uveitic reaction and a secondary glaucoma, and chances of amblyopia in such situation is very high. So management of subluxation, it could be non-surgical. So far the vision is comfortable in a good range of refractive error, and these patients are to be followed up regularly till they find some problem, and later on we can go ahead with the surgical management of such patients. The indications could be uveitic reaction, secondary glaucoma, changes in a subluxated or traumatic lens itself, it becomes a cataractus, and if the refractive error is not being accepted by patient itself. There are some older procedures, but those we are not dealing with nowadays. We are just simply going ahead with the closed chamber phacosurgery, PCIOL implantation, and using the different gadgets or the tools or the methods that fix up IOL in the bag or something other, so that patient gets a good vision correction. Those could be CTR, modified CTR, and a viscodispersive agent plays a great role in such patients. A thorough pre-operative examination is very mandatory. You need to assess the level of zonulolysis, the defect, whether the vitreous phase is broken or it's in the anterior chamber, angle evaluation, fundus examination, particularly of retina, and finally a B scan if pupil is not dilating and you're not able to see the fundus itself. Now coming to a few of the indications of CTR, what it does, it reestablishes the contour of capsular bag, avoids further extension of dialysis, prevent misdirection, irrigating fluid, and stabilizes the IOL in the bag itself. If it is a less than, slow phaco, and then you can go ahead, but you can put CTR at any time. What happens when it is more than 90 degree? You can make use of the capsule or the iris retractors, put CTR and the modified CTR. Maybe if you are not able to stabilize the bag, then you can have other options of IOL like iris clip IOL, AC IOL, or scleral fixation IOL. Cione ring can give you an advantage of fixing IOL in the bag. Time of CTR, if I just say, it could be as early as to avoid the complication, and it could be as late as till you can find your surgery is going smooth and you are able to manage the situation. These are the few sizes of Mosher's Cione ring, modified Cione ring. And then coming to few of the surgeries, like these two surgeries are running simultaneously. Here we can see in this surgery there is a deficit of zonule here. The viscodispersive agent has been injected, but unfortunately the axis has gone in an area of a loose zonule. So one has to be very careful while dealing with such cases, that try to see that your subluxation is not going to increase. You can keep trying with the forceps is an important tool in such cases that gives a good grip to the anterior capsule, and you could be lucky to, go ahead with the capsular axis. The important message is try to see the subluxation is not improving, not increasing. Use a viscodispersive agent, and the forceps is important tool to complete capsular axis in such patients. Now placing a CTR in such situation here, the lens is a softer one. It can be aspirated simply with irrigation aspiration, but try to see and keep an eye on the capsular bag all around, particularly the area of deficit. Whenever there is a fluctuation in the area of deficit, that is a time not to go ahead with the irrigation aspiration. Put a CTR and then you can do the rest of the case. But here, in this case, this deficit was more than 90 degrees, so with the hydrodissection, the CTR was implanted in the bag. The CTR goes smoothly and very easily in the periphery of the bag. Even you have seen in this case that the limb of CTR is being seen here. It is very well placed and stretching the bag to its last extent. Later on, you can complete the case. Now coming to this situation of a traumatic cataract, you can see a zonulosis in a lower area. I initially thought I might require to put a segment or maybe a modified Cione ring, so made a flap here, a partial thickness flap. And I could judge that yes, there is a dense fibrosis and a synecdoche between the iris and the anterior capsule. Now the capsular axis is being done, but since the capsule, anterior capsule is fibrotic, you may not get a curvilinear tear. Then you definitely need to adopt some other method. So this is how Vanna's scissor was taken into anterior chamber. The axis was completed. Later on, the iris hook to support the capsular margin so that the fluid should not go inside the zonule there was stretched, and whatever vitreous was there, because it was seen in pre-operative examination, the vitreous was taken away from the anterior chamber and the area where it was lying. The important tip here is not to, push saline while doing the vitrectomy, the vitreous goes back. And since it was a traumatic cataract, simple irrigation and aspiration taken away all the cortical material. I decided initially to implant this 3-piece hydrophobic IOL because the haptic, if I wanted to put in an area of zonulosis, I thought it might support it, and maybe later on, if I felt, then I could go with the Sioni ring or the segment. The same thing I did, and this is what it got stabilized. The reason of getting stabilized, and I tried to see that IOL is not pushed up anteriorly or no vitreous is coming up. The 2/3 of the bag was very much fibrous and very much formed and attached with the anterior capsule. So that gives me a satisfaction that this bag is not going to get subluxated in the future. So I simply didn't put anything. Now coming to this situation of a child, ectopia lentis, age is around 3 years. The intra 25 gauge infusion has been put into the vitreous cavity. The rhexis has been done. And all the cortical material has been taken away from the cortical bag itself. The empty bag was taken away from the vitrector, and the anterior vitrectomy was done. Now this has become aphakia. Since it was a child of around 3 years of age, this I usually do in a practice to implant the exact power of IOL in a pediatric patient who are below the age of 5 years, the iris clip IOL, so that amblyopia should not develop, and maybe later at the age of 10 years or 12 years, you can take away this iris clip IOL and implant the appropriate IOL, which is required particularly at that age of a patient with a biometry. Thank you. So
Thank you, Vijay. Meanwhile, I invite Dr. Maipal to speak on the role of femto laser assisted cataract surgery. One question, Vijay, why you are not, you are clipping it is on the anterior side. Why nowadays we are clipping it to the retrofixation?
Retrofixation. This is
So,
a little, this is a real, this was a little older.
older ones, okay, okay. So, so that was your, so okay, thank you, Vijay, for the nice videos. Anybody wants to add something for the subluxation cataract?
Thank you very much, Dr. Rajiv. Always a pleasure to be in your course. And I'll be talking about something that I've been, I would say, in love with for the last couple of years. Can you give my slides, please? And this is my surgery of choice today for cataract, and I think about 60 to 70% of my patients undergo the femto laser assisted cataract surgery. I'll be just talking about pushing the limits for flax as to how we can do difficult cases. You can obviously do the simple, but the idea for femto laser is not just to do the simple cases or the routine cases, but to simplify the complex cases. So there are a couple of situations that I'll be talking about. One of the situations which is definitely a fantastic situation where the femto works is the posterior polar cataract. And as we all know, in a posterior polar cataract, there is a pre-existing weakness in the posterior capsule. And what we do is that you get a pneumodissection because of the femto laser. Because in a normal phaco, you have to do a hydrodelineation or a hydrodissection. A hydrodissection in a case of a posterior polar cataract can lead to a split in the already weakened posterior capsule. Now, femto laser also, in addition to doing a pneumodissection in the plane that you want, it also does a nuclear disassembly and therefore reduces the time that you are spending for phacoemulsification. The biggest advantage that you have in a femto laser is that there is an integrated OCT that is there, and when you're doing an OCT, you get an image of the posterior capsule, and this high definition imaging will pick up, as you can see here, a posterior capsular defect, which is very, very clear here, and you can customize the offsets. So let us just see in this particular case, this is the defect, and we are moving these 3 bubbles, and this is where the nuclear disassembly will be limited. So this is the blue area where the nuclear disassembly will be limited, and you are creating a big epinuclear cushion for these particular area of weakness which is there. This was published a couple of years ago in JSCRS, and then you can see here that what we have been able to show is that there is a high specificity and a sensitivity that we have in these cases. Now let me just show you this particular case. You can see an obvious posterior capsular defect. So preoperatively we have diagnosed this posterior capsular defect which is there, and how are we going to maneuver this without having a nuclear drop. Sorry. So you can see here again, when we get the OCT image, you will see that there is this huge defect. You can see this area. This is a huge defect, this blue arrow which is there. So what we will do here is again to push this up. And once we are able to push this up, the nuclear disassembly or the fractionation of the nucleus will happen only in that area. So you can see that there is a big epinuclear cushion. This is the capsulotomy, and we are doing in the capsulotomy, we are getting these 6 quadrants we have made. So you can see a big posterior capsular defect, polar cataract. This is the MIOCT, that is the microscopic integrated OCT, and you can see that this is the defect which is being seen there also. So without doing any hydrodelineation, only with pneumodissection, you see that I have been able to remove the nucleus. Now the issue comes that we still have the epinuclear cushion that we had, so we will slowly and gently remove it, the cortex, without coming to the center. And when you can see that the defect is happening, you inject viscoelastic and do not remove this thing, and you can see this is not a broken vitreous, and you can see that we are been able to put a 3-piece lens. So this is the same thing as a photo essay which was published in IGO. This is the slit lamp picture. You can see that this is something that you can even pick up on the IOL master. So even if you don't have a femto laser, if you have an IOL master 700 or you have a good OCT in your clinic, you can pick up these pre-existing posterior defects, and normally at times it is difficult to make out whether there is a pre-existing defect in a polar cataract or not. So you will be much safer, and then you see that this is what we have done. This blue area is where we have done the nucleotomy. This is the MIOCT that is there. This is the defect, and this is the image of the MIOCT that is there. So epinucleus that you create in a flax gives you a shield, and that shield is available to you right till the end, and it is like you had the old cars without the air cushion or the airbag. And you can see that if you have the airbag, that is the epinuclear cushion for you right till the end, you don't have a problem and you are saved. Now, femtolaser assisted cataract surgery you can do in small pupils. Let me show you this particular video. So here you can go ahead and you can see that we are going to, in this particular case, put in a Malugin ring. So you can wash away the viscoelastic, put a suture, or you can increase the energy level that you are doing in the femto. So you can see this is a subluxated cataract. You could see the iris that was bowing up and down, and you can see that after putting a Malugin ring, even in this complicated case, you are able to get, because you want the least turbulence and the least manipulation in these particular cases. So we were able to complete this case. Now this is a case of phacomorphic glaucoma, where you will definitely get an Argentinian flag sign. You can see the iris is very close to the posterior cornea, and this you can see the huge swollen intumescent lens, and you can see because we are working in a closed chamber, you could see a gush of fluid that was coming out of the intumescent cataract, but despite that we were able to get a good capsulotomy, and getting a good capsulotomy is more than half the battle won in a white intumescent cataract, and you can see that we are able to go ahead and complete. Let's look at flax in rock hard cataract. So this is a rock hard black cataract which you can see, and As long as it is not a white cataract and the laser is able to focus, you will get the crack. And just watch here. Can you see those air bubbles that came out? So that clearly indicated, and you can see it's a black cataract. It's one of a very, very hard cataract. But the chopping that has been done by the Femto reduces the amount of energy that you are using, and in these we do a slightly larger capsular axis, which is about 5.2, that extends to 5.5. You don't work with a smaller capsular axis in these particular cases. Post-traumatic subluxation you can see in this particular case, and what we have described just now in the IGO is a limited pars plana vitrectomy for optimizing surgical outcomes in these subluxated cataracts. So just see here, this is a vitreous blob. I don't know whether you can make out which is there. And you can see that the iris is down. So what we can do in this particular case is to center the capsulotomy. So we are doing a custom center. We wanted to put it on the centration, which was on the capsular center, but we couldn't get it because it was cutting the iris. So you can actually move the capsulotomy after getting the OCT image and do it. And now you can see we have got a very good capsulotomy. We have broken it into 6 quadrants. There is a vitreous here. We have injected tricot, and you can see before we go in, we are using this to take away the vitreous which is coming forwards. Okay, so this will be a decompression of the vitreous, and you will not have hydration going in and increasing. So now we are putting in the ECR, and you can see because there is a nuclear disassembly that we have done already, we are able to take away the nucleus pretty well, and you can see that the whole thing is centered now because we have removed the vitreous, and we have also done the decompression of the vitreous, as we can see, and the endocapsular ring was added so you could see the whole thing. And we can go ahead and finish this procedure very well in this particular case. We are putting a 3-piece lens to get a good outcome in this particular case, post-traumatic subluxation. So friends, I have shown a couple of cases where I would say that Femto is the leap in technology that has happened, and it's a leap of faith, I think. More and more people are going in for the Femto technology, and this is proving useful not just in the routine cases, but also in the complicated cases where I think Femto will have a great role to play to give you great outcomes. Thank you very much for your kind attention. Thank you.
Thank you, Mahipal, for excellent presentation and elaborating the use of the Femto laser. Now I invite Dr. Harbans Lal to speak on the soft, mature and hard cataract. Dr. Harbans is the President-elect, Vice President-elect.
Vice President-elect, Vice President-elect.
अच्छा, Vice President. अरे यार ये सब गिमिक आप लोगों को आइडिया है यार.
क्यों हो गया?
5 मिनट तो बैठना भाई. जाने अच्छा ओके.
So good afternoon, friends, and thanks Dr. Rajiv Choudhury for giving me this opportunity. So I'll be talking about 3 different scenarios in a cataract surgery. And we all know that the nucleus has to be removed in the central safe zone. No phaco should be performed in the peripheral unsafe zone. So what we normally do, we nudge the nucleus with the foot pedal position 2, and then we give a little bit of energy to get our tip inside the nucleus in foot position 3. Then bring back our foot to the foot position 2 so that the nucleus is held with a vacuum seal or lollipop the nucleus. Then we break it or chop it and then pull into the central safe zone, and then we aspirate. So what happens in this soft cataract, because the cataract is too soft, as soon as you apply vacuum, either it gets sucked or you will have to keep the vacuum very low. At the same time, epinucleus is very sticky, which keeps it held over there. You're not able to pull it out, with the result that the nucleus gets sucked into the peripheral unsafe zone. So there is a very simple technique for doing all this. You will never have a PCR. You make a trench. I'll show you this. We have made a trench. Now after making a trench, we rotate it, and once we try to hold this nucleus, we nudge it, go inside, bury it, nucleus is held firmly, separated, and then we try to pull out. We are not able to pull it out because the epinucleus is holding it. Then again we try it, and again after coming out to some distance, it goes back. So our all attempts to pull it, now what has happened that the tip of the nucleus are already eaten away. So now if I try to remove it, I'll go into this unsafe zone, and over there slight vacuum and you will have a PCR. So now I'll show you the another part where what I'm doing over here, I'm close to the capsular access margin, and with a vacuum setting of 100, 200, 300, 400, whatever it may be, it is okay. I'm trying to remove the epinuclear plate between the anterior surface of the nucleus and a capsule. So that the epinucleus which was holding it back, I have removed it just by suction. So once this epinucleus plate is removed, you will see that this nucleus comes out very easily. So simply remove the epinucleus plate between rim of the anterior capsule and the anterior surface of the nucleus, then you will be able to pull the soft nucleus at 80 vacuum setting. And there are many methods because I got to cover 3-4 topics. The same technique you can adopt at any time. You feel the nucleus is not prolapsing in between, or even in the beginning of the surgery, the cataract is very soft, you can remove 273, 300 degree soft epinucleus, and then you can prolapse whole of the nucleus and remove it in toto. So this technique can be applied at any time. Anyway, now this, whenever we are talking of the mature cataract, we know that there is a chances of runaway rhexis. So the initial is, and usually this rhexis, sometimes if you puncture it goes away, then you can't help it. I mean, you are helpless about it. But sometimes when you go, say, beyond a 4 millimeter zone, suddenly you see that it has run away. So we have a tendency to do it in one go. So there are many methods. So you can have a double rhexis, triple rhexis, a spiral out rhexis. So there are many methods described. So this is just I'm showing you where we have done a very small rhexis, and then we thought this may not be safe to do the phaco. Then we make a little larger rhexis where the phaco can be done. And but once we remove this nucleus, and after putting the lens, we feel the rhexis may be still small, and capsular phimosis may bring it too close. So you can have the triple rhexis in the same patient, then you can enlarge the rhexis even afterwards. So initial small rhexis just to prevent sudden going out of the in a mature cataract, running off of the rhexis or getting it here. So this is just, we are using a, at that time we had no actually dedicated capsular access forceps. So this is a borrowed ILM pilling forceps from a posterior segment colleague which you can use. But this becomes a little difficult to use from this side port. So now I come to the hard cataract. You need to have a very high vacuum setting and a very good power setting so that you don't push. And very important to use the very long chopper and use the regular tip. Don't use micro tip. Don't use micro tip. That's very important because the hold will be very poor in a micro tip. When you use a regular tip, the hold will be doubly strong on the same vacuum setting. So we do this rhexis, and after doing rhexis should be a little on the larger side. That means when I say larger, it should be around 5.5 millimeter. Definitely not less than 4.5 millimeter in any case, so that you can make it well. I have not done any hydro. So the trench has to be wide, because when you want to go to the depth, which is very thick, so the sleeve keeps on getting obstructed, you are not able to reach to the depth. So if the wrench is in a V shape, because the tip and sleeve becomes a V, so if you make a trench in a V shape, when you rotate, your sleeve will get accommodated very easily. So it has to be V on the top, it has to be V at the depth also, so that you can reach. So after making a good trench, if you do the hydro dissection beforehand, then the nucleus keeps on rotating when you are trying to push it. So in a very hard cataract, I do not do hydro in the first part of the trench because 80-90% of the trenching has been done. So I inject a viscoelastic before withdrawing my probe, my tip out. I inject the viscoelastic. Now I am doing the hydro. So now I'll do hydro dissection. Hydro delineation is not required, but this whole part is nucleus. And after doing this hydro, then I rotate this nucleus, and you will see that once we rotate it, the wider portion will come sub-incisional, which will be able to accommodate the sleeve very well. So we rotate it, and the another important point is that the central part initially the hardest part is not the deepest part. So suddenly you will see that certain chunk has disappeared, you start seeing the bright reflex, then you come to know that the toughest part you have broken. And many of these patients, even when the nucleus is broken, the part of the epinucleus, or what we call as a leathery plate, that becomes very leathery, which you are not able to break. So the central part of the, in this case also the same scenario, the nucleus was divided, but there is a posterior leathery plate which is very difficult to break. So I'll show you my technique how to do it. So split it. When you try to split it, you can see that the periphery is getting pushed and you will unnecessarily damage over there. So now what I do is, at a vacuum setting of 600, I'll just hold one end of the heminucleus at the corner where the crack is starting. Now this is a 600 vacuum, and now I pull it with the chopper and split it like this. So like we used to do in a rhexis, tangential. So now one fiber is broken at a time. When you try to do it this, you're trying to break hundreds of fibers in one go. So slowly and slowly you see that it starts splitting, like Bhima pulled the leg of the Duryodhana. So same way you pull it, separate it apart, and now rotate it. Do the same thing, repeat on the other side. Hold with a high vacuum setting of 600. Go there, separate it. Once you get two segments, the rest of the surgery is very easy. Try to make smaller fragments. Always try to put the chopper where you want to have separation. Don't try to keep on pulling away. So keep on focusing and make a rotation like this. You'll be able to pull it out. And then bring them. Chopping I do because as long as the nucleus is in the capsular furnaces, there is no chances of PCR. So don't be scared. Use 600, 650, maximum vacuum is available. But as you keep on removing nucleus fragment slowly and slowly, and the nucleus back keeps on become empty, at that time you keep on lowering the parameters. So when you are doing phaco aspiration, my first fragment is at 600, then 550, then 500, 450, 400. So by the time I reach the last fragment, my vacuum settings have got down. Chopper from the sharp I have shifted to the smaller chopper. I put on a viscoelastic to make the capsule safe. So thank you for this, but the basic is phaco tip should be, setting should be very high, the tip should be large, incision should be as posterior as possible without cutting the conjunctiva. Cysts should be larger, particularly in front or closer to the nasal side where you are going to do the chopping. No hydro initially. Wide and deep trench, because the energy used for making trench causes no collateral damage. It is only when you are delivering close to the cornea it will cause damage. So absolutely don't hesitate using extra energy, and divide the nucleus into small pieces, and initially use a long chopper, then can go to the small chopper away from the cornea. Make a conscious effort to all the phaco should be done away from the cornea. The day I decide, irrespective of the hardness of cataract, if I decide that this patient should have clear cornea next day, that patient will have a clear cornea next day. It is only when you be little lethargic and be little careless, you develop the corneal edema. Thank you very much.
Thank you, Urbans, for nice videos on the soft cataract, mature cataract, and you made a job easy. And now I invite Dr. Rajesh Joshi to speak on advancement of IOL's multifocal IOL. As we know, after performing the good phaco, the quality of vision we have to give by the toric or multifocal toric. So Dr. Joshi is elaborating on this.
Good evening, one and all. At the outset, I thank Rajiv Choudhury sir for giving me this opportunity. Most of the advancement in cataract surgery is occurring either in the phaco technology or in the IOL. And I suppose the technology is advancing towards smaller and smaller incisions. We have newer injectors, we have newer IOLs. So let's see what are the advancements which are occurring in the multifocal IOLs. Nothing to disclose. The biggest disadvantage of monofocal posterior chamber IOL is presbyopia. Sometimes we see that the patients were happy before cataract surgery as they had a nuclear cataract and the vision was perfect for near. But later on they find that you are deprived of them by using their near vision by removing the cataract. Now, most of us, they are unhappy with near vision, particularly intermediate vision after cataract surgery. And intermediate vision has become important, particularly for those who are using mobiles. And after COVID, I suppose, we have forgotten to see the distant object. The quality of vision required for near and the intermediate is the most important thing while working on the computers, while navigating on the car, during reading, or mobiles, tablets, and all. The options which are available for near vision correction after cataract surgery are monovision, but they have their inherent problems like loss of stereopsis, bifocal glasses. The cosmesis is a problem, particularly in young patients, multifocal IOLs, accommodative IOLs, and the recent ones are intermediate, monofocal IOLs with enhanced intermediate visions. The monovision, the one eye is made myopic and other one with normal vision, that is preferably with no glasses. The myopic eye is usually non-dominant one, but there is loss of depth of perception and the binocularity is also lost. Accommodative IOLs, they came in the market very fast and they disappeared also. It's monofocal, pupil independent, no rings in the center, so no halos and glare. But due to contraction of the capsule, the near vision usually do not remain for a long time. So the long-term visual outcome is a problem with accommodative IOLs. Multifocal IOLs are useful particularly for those patients who desire of spectacle-free vision. This is a problem because they cost a lot, and the cost is a problem particularly in the post-operative period if the patient is unhappy with multifocal IOLs. No retinal pathology, no gross cylinder, but gross cylinder can be corrected if you implant toric multifocal IOL, accurate intraocular lens power, which is stressed many times, and of course it is important, perfect surgical procedure. But they have their problems also, loss of contrast and glare and halos. Less now mostly in the recently developed IOLs. Now if you see the evolution of the multifocal IOL, it is from split bifocal, that is upper segment for the distance and lower one for the near. Now no one uses these IOLs. Refractive IOL, it has got concentric rings or zones, and they have zones for the distance as well as for near. These IOLs are dependent on the pupil. If there is small decentration of the pupil or small decentration of the IOL, there is always a problem with the visual outcome. Diffractive multifocal IOL, they are perfect for distance and near, but the intermediate vision is a problem. And a spectacle, particularly for the younger ones, and glare and halos could be a problem in these IOLs. Newer generation IOLs, that is a trifocal IOLs, they have extended range of vision. And the optimal visual acuity you can obtain for the distance, near, as well as intermediate vision. Initially, we started with multifocal IOL with add of 3.5 to 4 diopter in the center. But the intermediate vision was a problem. Excellent result, most satisfied were hyperopes and particularly those housewives. But the intermediate vision was a problem in those IOLs. Now, with the development of trifocal IOL, with low add, there is a flexibility of using IOL according to the patient need. If the patient is putting near objects at a distance, you can have low near add. If they are using the objects for near, close to their eye, then you can add more for these IOLs. The advantage of this IOL is diffractive zone, that is, they have less dependent on the pupil size and the lighting conditions. Smaller diffractive zones compromises on near and intermediate performance in low light or in large pupil patients. Larger diffractive zones compromises distant vision in mesopic condition. But with the development of this IOL, there is a maximum light transmission that allocates for the near as well as for distance. That it transmits as much as 88% of the light at 3 millimeter of the pupil size. And this allocates half of light for the distance and half is split into near and the intermediate vision. There are various types of IOL which are available. How does light utilization matters? It impacts contrast sensitivity and quality of vision. More the light transmission, better the quality of vision at all distances and the excellent performance. And as far as material is concerned, we prefer hydrophobic compared to hydrophilic material because of less PCO and the biocompatibility of the IOL. And there is refractive predictability in these IOLs. Excellent long-term outcomes are possible with the hydrophobic material. Your surgery has to be perfect. You can stain the capsule with the help of Trifam Blue and perform Rexis the way you want. And whatever procedure you are following for the removal of the nucleus that you can do, may it be a stop and chop or direct chop, whatever. But your procedure has to be perfect, cortex removal and the implantation of intraocular lens. Make sure that the loops are well placed inside the bag and the capsular axis covers the optic of the IOL. Thorough viscoelastic wash is also important. Now there are other lenses which are available. Those are the extended lenses with extended depth of vision, and those, they don't have rings. The best part is that they don't have rings, and the glare and halo is not a problem in these IOLs. But sometimes if the patient is reading at a close distance, they may need some near vision corrective glasses, maybe lesser than what we give in our routine cataract surgery, maybe add of plus 1.5 to 1.75 diopter. Now these are the new IOLs. These are presbyopia correcting IOL, non-diffractive monofocal IOL, extended depth of focus. The one of them is the VVT1 from Alcon. No split of light, therefore excellent distance and intermediate vision, and a functional near vision, but the cost is exorbitant. The mechanism of action of this IOL, they have a small central ring, and the central ring is one part of the ring is slightly elevated and a smooth plateau. The elevated part gives the near vision, and the smoother part gives the slight curvature part give the intermediate vision. The another one is the Lucidis IOL. I don't have experience about this IOL, but just to complete the list, is available. It is a refractive one, hydrophilic one, and a pseudo non-accommodative IOL. The light distribution is uneven in these rings, the 52% for the distance and 23 and 25 for near and the intermediate vision. As far as Indian scenario is concerned, you have to spend...
Rajesh, just summarize, please.
Yes. You have to spend more chair time, and ideal patient selection is crucial. The technology is expensive, but with the Indian IOLs which are coming up, they are no more expensive. The cost of surgery has gone down. But you have to deal sometimes with unhappy patients also, in spite of good surgery. And how to avoid these unhappy patients, improve biometry, correct astigmatism, precise fit IOL, perfectly fit IOL, and well-centered IOL, that is very important, and improve the corneal surface. Thank you all.
Thank you, Dr. Joshi. Now I will invite Dr. Rajiv Choudhury again for the last presentation of this course. As we are running short of time, I'm sorry, but we cannot entertain any questions.
We might have because my presentation is 5 minutes only.
Oh, that's good.
So I will be speaking on another technology we have seen, the FECO, all type of the rings, Femto, is the roll of eye trace.
सब ये बीच वाली सीढ़ी है ना, बीच वाली ये एस्केलेटर है ना, इस बीच में वो अच्छा है, वो ऊपर नीचे सब तक जाता है। लास्ट में एक फ्लोर के लिए तो बीच वाला अच्छा रहेगा।
Role of eye trace in detecting the correcting aberration in cataract and refractive surgery. I will going to cover on the cataract surgery. Because it helps in the selection of the patients for aberration-free lenses, selecting of the multifocal IOLs, because that requires a premium cataract surgery is premium, which I all discuss. We have the IOL calculation, IOL master, phaco machine, premium IOLs, and aberrometers. Still, sometimes we have refractive surprise or unhappy patient. So there is a new concept, the eye trace visual function. It is basically ray tracing wavefront aberrometer and the corneal topographer. It is a 5-in-1 system, ray tracing, it gives the aberration, then corneal topography, auto refraction, auto keratometry, and the pupillometry. So it's 5-in-1. And what is the role in, what does eye trace do basically? It is given the aberration and the corneal topography. So basically is give the pointer, please, total aberration, and it gives the total aberration and the corneal aberration. So we just detect the total aberration minus, so you can get the internal aberration. How it is important? So we can select, evaluate the premium IOL, aspheric, multifocal, toric, accommodative, and selection of that dysfunction lens index, whether the patient is a refraction increasing or the lens is a problem. You can have the DLI and post-operative evaluation of the unsatisfied patient. It is a pitfall. We have to head movement. Measurement is an important issue, just I skip. So this is the total aberration. You can give optical quality metrics and it gives the simulated. So these are the data you get, a retinal spot, how much a single spot make it is like that. How is your image you form, and which is a dilated pupil, it is 5 mm. Eye trace demonstrate actual vision problem patient is having. It gives angle kappa, angle alpha. So you can have the misaligned multifocal. So this is the option. This is the internal aberration. This is the corneal aberration. This is the total aberration. As there is a few corneal aberration, you remove the cataract, there is a removal of this aberration will go. So these are the good candidate for the multifocal lens. Suppose this corneal refraction aberration is high, and if you give the multifocal lenses in this is going to persist and the patient will be unhappy. So it decide, perform eye trace. This is the method what we are doing. High angle alpha. If you want to go consider monofocal, if there is no high angle alpha, you can go analyze corneal optical quality with change analysis. If a corneal high order aberration is there, you again go for the monofocal, not for the multifocal. If it is a low, you can go for toric candidate. You can go for toric multifocal, or eye trace, you can plan it. So in this way, you can detect the customize, you can select the lenses, you can have the aberration. There is what we are mostly talking of the aberration-free lenses, negative aberration. But what are the options? There are the multiple lenses which are negative aberration, zero aberration. Suppose that cornea is having positive aberration, we can put the negative aberration and it will neutralize. If suppose cornea is having zero aberration and we put the negative aberration lenses, we are creating the more aberration. So these are the fine tuning of the cataract surgery. You can select whether the it is the option of the refractive ectasia is developing in the refractive surgery. There is a change in the refraction. We see that is the LASIK, the refraction is regressing, but probably there might be change in the lenticular changes which we can detect by DLI. So in short, this is about the eye trace in the cataract surgery. This will help to you customize your, this is dysfunction. You can see that there's a patient, his vision is 6/6, but the quality of vision is like this. So you can detecting the dysfunction DLI, and you can select and advise, and you can have the good reason. This is one of the refractive surprise. We have a 40-year patient, monofocal, both eye vision 6/6, and he has severe dysphotopsia with the, and this is the quality with the 6/6. This is the quality of vision with the You can see patient is pursuing and literally he is having the dysphotopsia. These are with the 4 mm, this is the quality of vision. You can see there is a change, that there is a monofocal, this is indicating that you should change. So slightly because of the fibrosis, there is a tilt and creating the aberration. So in this, the monofocal, this is the monofocal hydrophobic lens, and we have just rotated it, and you can separated the fibrosis, so that, and this give how you can see that quality of vision is improved after the rotation. The both are having the 6/6, but the quality of vision is, patient is heavy. You can see what was the aberration previously and this aberration later on. So this proves that it can, there are other toric IOL, and you can select that quality of vision. This give you this much rotation is required, and this will be the quality of vision later on. So in short, this is about the eye trace. You can help in the selection of the lenses and assessing the unsatisfied patients. Now,
Rajiv, I have got a question.
Yeah.
If you take a wavefront aberrometry on eye design and do the pentacam corneal topography, can you subtract that from this and find out what is the internal aberration or no? One is that you do an eye trace, which is dedicated equipment for that. But if suppose I don't have eye trace, but I got a eye design and I got a
I don't know.
corneal topographer. So if we take a total aberrometry on a eye design,
Broadly, you can do it, because that internal aberration is because of the cataract and vitreous. So mostly because, and that is the dynamic. So it helps, and it increases your quality of vision, and selecting and help in some of the patients is very well, especially in the post-operative dysphotopsia. It will help very much.
Corneal machines are going to read the corneal statistics only. They are not going to give you the internal.
no, because wavefront will measure complete.
But that give total aberration.
Yeah,
That
wavefront will
includes
give you total aberration.
total
Corneal will give you corneal, so subtract the corneal from the wavefront.
But here comes the every.
I'll go and analyze and then get back to you, whether that is possible.
Anybody has any question with any of the speaker?
I'll just like to give some suggestions on a multifocal IOL. One is that anybody who is putting a multifocal IOL must know how to explant it.
Yeah.
If you do not know how to explant it, please do not put it. Well, then you will be defensive throughout. And IOL explant is very easy. Companies usually take it back, so do not wait for the opportunity to do the explant. Next day you put on a lens, put hyaluronic acid and sodium hyalurate and cut it and remove it, so that whenever the need be, you are relaxed and you can remove it. Secondly, whenever you use the low power lenses like EDOF, Symphony, place slightly on the minus side. Normally I take second minus of the chart. But whenever you use high power like Synergy, Panoptics, which has got a very close reading range, say 33 centimeter. So in that it should be the first plus or emmetropic, not the minus. Because if you put on a minus, the reading distance will come much closer and halo will become much bigger. So whenever you are using the high power lenses, and all of you must know how to plot a defocus curve to understand how it works. So if you are not already understood what is a defocus curve, go back and read it, what is a defocus curve, so that you understand how these lenses are going to work, different lenses. So what is the one peak, what is the uniform, what is the second peak, at what it is, at what distance patient is going to see. So defocus curve is very simple. You put on a distance correction, suppose patient is 6'6", then keep on putting the plus lenses on top of that, minus lenses on top of that. So wherever patient, how much minus, suppose patient minus 1.5, he can still read 6'6". That means at 75 centimeter, his vision will be very good. So you go and analyze it, so that you can analyze your patients, what they are feeling, and you can analyze the IOLs also. You're not only dependent upon the company, what companies are telling you, but you understand how this IOL is going to work in the patient eye.
Thank you. Dr. Shroff, anything?
No, thank you very much. We enjoyed.
So, friends, it's the end of our session. I thank you, our all speaker, Dr. Harbans, Dr. Shroff, Dr. Nishlani, Dr. Rajesh Joshi, Maipal, and thanks to all of you to be here. Okay.